all. This is Dr. Mubin Sayed from drbeen.com. Today we have a star. We have a celebrity. We have a friend. The world is small. We both have a mutual friend, Dr. Ahmad Zafran, who was medical director for drbeen.com. Ahmad Zafran and Dr. Yo here, which I'm sure that you just looked at him and you recognized him from the work he's doing on YouTube and social media. They were anatomy partners. So I did not know this before, but this is awesome and this is amazing to know him and to know his work. So just a brief bio for Dr. Yo. He is an anesthesiologist. Before the medical school, he was a hospital infection control practitioner and also worked for the Florida Department of Health HIV/AIDS division. He is also a medical director of a performance sports and wellness center in Rhode Island. So Dr. Yo, welcome.
Thank you, Dr. Bean, and thank you for the really kind words. I just also want to say I'm a big fan of yours. I'm one of the cool beans, and very grateful that you let me on your show today.
No, so this is actually, the honor is ours. Cool Beans, the community has been asking to have you with us for some time. And I have been not reaching out. I said, well, Dr. Yo is a celebrity. Would he even decide to come on or not? And here you are. So thank you very much for accepting our invitation.
Well, thank you, Dr. Bean. I'm far from a celebrity. I never intended to be on social media and on YouTube, but it's very humbling how much we don't know in medicine and how every day is a learning experience. So it's interesting. You call me a celebrity. People call me an expert, or they ask my opinion on things. The interesting thing is I learned so much from the viewers. I learned so much from people on YouTube, on Twitter. And I actually, just like you, and I follow you on social media and I follow your videos. I know that you engage with everyone. You try to give an answer to people, and you take the time. And I try to do that because I learned so much. I didn't know about leronlimab. It was people on social media that told me about it. Friends of mine, they said, look into this. Even many other drugs, vaccines, new therapies. One person cannot really know everything. So it's so humbling. And I always make, when people say, oh, you're the expert. So no, we are all in a community together. And the nice thing too is you see this in other YouTube channels with music and film, where you start creating a community. Everyone supports each other. And it's just wonderful that you have doctors. And again, thank you again for having me on, where we are able to create that community of like-minded people, not spouting out conspiracy. And we're really engaging with people. And it's just so humbling to be part of this.
I totally agree with this. And this, the point that you made, that none of us were aware of how to take care of this new virus. This was a novel virus. And it did not, I say very often in my talks that it did not come with a manual to say, this is how to treat me. So WHO did not know it, and CDC and FDA and us and others, they did not know. And what came handy was the knowledge that we had been given when we were studying, and the way to learn. So in medical schools, they don't only teach you the mechanisms, they also teach you how to learn and how to think. So I think that has been the basic gift, and it is in all of the healthcare professionals. They think about it or they don't think about it, this is there. So thank you very much for the work that you've been doing. Thank you very much for the leadership that you've provided. I have a few questions as well for you, for our cool beans. So if you're ready, I'm going to start.
I'm on the hot seat. Usually it's the other way around. I'm the one interviewing, but fire away, Dr. Bean.
Excellent. This was actually the strategy, to bring in someone, and then I am not in the hot seat. You are the one. So let's start. So the very first question that is in my mind, and I think many of the cool beans as well, that is what are the treatment options? The outpatient, inpatient. I think that these stages of the disease, we have asymptomatic patients. We don't know, they don't know. And so there is not much other than asking everyone to have a better immune system. Then there is mild, moderate, severe, critical, and nowadays the long haulers as well. So what have you seen in terms of practice, outpatient, inpatient? What are the options?
Yeah, it's a really great question, Dr. Bean, and thank you. the interesting thing is what I'm going to say today, or the way I look at it, is completely different than it was 3-4 months ago. And you ask me the same question maybe 2 months or even a month from now, and my answer will be different. I think most of us would probably say that. If we're looking at where we are today, everyone has a different their phases. I sort of look at it as 4 different phases. I look at the asymptomatic, virally induced, immunological, and post-COVID, or AKA the long haulers. And I think it's really important, just going back to the earlier in the pandemic, as you were talking about earlier, is we didn't understand sort of those phases. And when you don't understand those phases, then we give medications at inappropriate times. For example, when we were looking at hydroxychloroquine, a lot of the ICUs, they were giving hydroxychloroquine, azithromycin, a lot of times not even zinc, to patients that were intubated on pressors and saying, oh, it doesn't work. I have so many ICU doctors that saw that. I've reviewed a lot of charts. And likewise, the thing with remdesivir, tocilizumab, we didn't really know, and steroids, there's been a lot of discussion about steroids. People were giving it in the beginning, or it doesn't work. Giving at the end, it doesn't work. We didn't even know what doses we were giving. People with hydroxychloroquine were giving 200 milligrams. Some were giving 800 milligrams. It was just, let's throw something against the wall and hope it sticks. And there's nothing wrong with that. I mean, this is a new virus. But I think now we have a better understanding. So one of the things, I learned so much from talking to patients, being on social media. I've actually connected not only with people on YouTube, but Instagram. I have patients contacting me. I have families from Pakistan, from Afghanistan, from India, from South Korea. They're asking me, and I'm learning about other things in other countries. So if we were looking at the asymptomatic phase, I mean, those are the people that are going to get infected, but they're not showing any symptoms. And why that's the case, there's a lot of different immune responses. Some people have a strong T cell response, or I think there's some studies showing that previous exposure to coronavirus has some sort of T cell like memory, even with influenza. So it's a very interesting, again, before I continue with that question, I was talking with another virologist, not Dr. Patterson, but another virologist. And he said, we learned so much from HIV about the immune system and about the body, that COVID, this whole pandemic, we're unlocking something else different. We're going to learn something more about the immune system and about the body. And I feel like almost every day we're seeing there's some new studies. So in terms of the asymptomatics, I think those are the people that are going to get infected, which a lot of people, and they say, I don't even know. And I had to get a test because from work, or a lot of times it's work. You see a lot of professional sports players, they'll come on Twitter or Instagram and they make a little video like, I didn't even know I had to do this to get back to playing. And I was out lifting weights and playing ball with my teammates. So that's just really interesting. You see that population, and then you have the virally infected. That's the next phase, and they're the ones obviously we all know as the symptomatics, the fever, the myalgias, the diarrhea, the loss of smell. So the question is, we can talk about experimental drugs. A lot of people are very angry. I see messages about the FDA, the WHO, the CDC, and as a clinician, the important thing is there's a time and place for those discussions. Right now, we're still in the middle of the pandemic, and we need to come up with solutions and treatments for people. As I listened to your interview with Dr. Bartlett, very interesting with the inhaled steroid, budesonide. See, half these drugs I can't even pronounce. Dr. Zelenko's protocol with the hydroxychloroquine and zinc. I think Dr. Marek and the MAT protocol. One of the things I want to say that it was wonderful you brought these doctors on. I had Dr. Zelenko. I spoke with him on my show a couple of weeks ago, and many of the other experts you've had. Is I appreciate the fact that they took all this information and organized it. Now, I can disagree with something, and we can respectfully disagree and say, well, something, Dr. Zelenko, I don't know if hydroxychloroquine has a role in prophylaxis. I'm not sure about that, but I respect the fact that you organized it, put it in a way that made sense. Same thing with Dr. Bartlett. Dr. Bartlett, the CEO or the CMO of the hospital he was at, I went to medical school with him. Actually, Ahmed went to medical school with him. And I read some of the comments the hospital said. They tried to distance themselves from Dr. Bartlett. And I listened to his talk when he came on your show, and the empathy, how much he cared for his patients was so evident. He was an advocate for his patients. And I appreciate doctors like that. Same thing with Dr. Zelenko. Again, we can talk about, we disagree with something, we can do that. That's medicine. There's 100 different ways of skinning the cat. But Correct. Unfortunately, because of the politics, the finances, whatever it is, the reality is a lot of these drugs are not available. Hydroxychloroquine is not available. Most physicians are not prescribing it. The FDA's pulled out the EUA. The other thing is the steroid that Dr. Bartlett's talking about. I'm not quite sure if a lot of physicians are prescribing that. They're going to say, oh, it's a steroid. They're going to say, look at that UK study, even though it's an inhaled steroid, and they were looking at dexamethasone. I think there's a difference. I agree with Dr. Bartlett. Administering an inhaled steroid, you're directly administering a medication versus an IV, which can cause more systemic problems. But I worry that that's an option that most physicians are not going to consider. And then the other doctor is who's the other one that you had? You had Dr. Dr. Merrick, and the MAP protocol. Yeah. And I really, it's funny. I call it the Yo. Some people have called it the Yo protocol. It's more of a modification of Dr. Merrick protocol, and it's very interesting because I've come to appreciate that a lot more than I did earlier in the pandemic. And same thing with Dr. Zelenko. I was a little critical about hydroxychloroquine because I was looking at it from the perspective of an ICU, and I was like, well, this doesn't work, and why are people talking about it? But then the more I looked into it, I know you've talked about it in your videos. A couple of others have. I spoke to many physicians. In fact, it was the physicians overseas in Pakistan, in India, that said they were using hydroxychloroquine and having some benefit. And that's when my eyes open. And this is where the learning process comes. You have to be real humble and just not be very, this is my way. Just say, listen, I think I'm going to reconsider my stance on this. So, but the Merrick protocol, if you look at it, a lot of people are like, well, vitamin C. I don't really, there's no randomized control study on it. Vitamin D, and the melatonin. So the question is, okay, if you're going to say no to everything, what do we have? Because we do have sick patients.
Absolutely. Yes, please.
So, and so in the last couple of weeks, I've had quite a lot of patients contact me. I've never met them before. I have a friend of mine from residency. He's an anesthesiologist. He's got COVID right now. Called me up about 2 weeks ago and he said, what do I do? And this is a physician. He's a board certified, very intelligent doctor. He said, I don't know what to do. And he said, you've really been on top of this. What do I do? He's like, I can't. I'm not, obviously not going to get hydroxychloroquine or steroids. So I said, go to CVS. I said, right now in the United States, we go to CVS and we get, that's how mild COVID-19 is managed. Go get zinc, quercetin, vitamin C, vitamin D. I think I'm a little bit of a fan of N-acetylcysteine, the NAC.
Me too, big fan.
Yeah, exactly. And so, I know Dr. I don't think it's in Dr. Merrick's. I think he's got famotidine. And I'm not sure about famotidine. I mean, I understand the mechanism behind it, but I personally find N-acetylcysteine to be a little bit. Again, it's anecdotal. It's all opinion, right? So you might say, listen, I think famotidine might be better. I said, okay, that's wonderful. Hey, how is it going with you, with your patients? Can you tell me about it? And maybe we all have to be open-minded. You can't be like, well, this is my territory. This is my drug and my protocol. So that's really where we stand right now. It's like, what else do we give? Because I had a patient a few weeks ago, and his daughter called me. He follows leronlimab. You've seen my videos on leronlimab. He's an investor, and I actually have permission from the family to talk about. His name is Fred Rodstein. And his daughter, Amber, texted me on Instagram at midnight from Washington State. So my dad is in Phoenix and he's got COVID. What can I do? I said, well, they try to get leronlimab, but it's difficult with these experimental drugs. And then his liver enzymes were elevated, so he was not a candidate for remdesivir and tocilizumab. And so he stayed in the hospital for a couple of days. And his daughters texted me, talked every day. And I said, well, what did they do? Well, they just gave him supplemental oxygen for 2 or 3 days and sent him back home with some Tylenol and some fluids. And God, I can't imagine what that hospital bill is like. And that's when I started thinking to myself, we really don't have, outside of CVS in the United States. Now, interesting enough, I know you've talked a lot about ivermectin, and I've been following some of the research in South Florida and Bangladesh. Dr. Alam is doing some really interesting experiments. And about a week ago, I spoke to another researcher, Dr. Mohidin, who's he just published a preprint on a paper looking into ivermectin and doxycycline. And he's found that and he compared it with the control arm was hydroxychloroquine and azithromycin. They gave zinc to all their patients. They gave zinc and vitamin D to all their patients. But it's very interesting. He said they're having better outcomes with ivermectin and doxycycline. So again, it's I think there's a lot we can learn from other countries. That's the one thing. Sometimes living in the United States, it's a great country, a lot of opportunities, but mild to moderate COVID-19 managed at home, CVS. I mean, I don't know anyone that's going to touch ivermectin. The FDA came out in April and said, we do not advise. So people are terrified of giving ivermectin, even trying out. So that's, I think that's where we are right now. In terms of experimental drugs, there's a drug called EIDD 2801. One of the things that I look at when I'm looking at these experimental meds, there are literally hundreds of these medications. I think when I was talking to Dr. Patterson a couple of days ago, I think I said on my show, there's over 200 experimental drugs, and I got all these messages. What? There's 200? I said, well, no, there's probably more. This is just what I've just been able to eyeball. How do you keep up with that? And what I've done is I sort of have like a scoring system in my head, and it's an 8-point scoring system. And maybe I'll just share it with your cool beans, because this is how when I'm looking at a drug, or even a vaccine, this is what I sort of use to say, is it, how clinically relevant it is. So I look at so I'll run through the 8 points and I'll just hit the major things. One, I look at the mechanism of action of the drug. I look at the safety, the efficacy, the route of administration, where in the developmental phase they are, the exclusion criteria, price, scalability. And I would say, like,
beautiful.
I would say price and scalability as a clinician. I am aware there are always political and financial implications, and we have to take that into consideration. But when I'm just looking at it as a scientist and a clinician, I to be honest with you, I haven't really done a lot of research, but it is important. I don't want to discount it. So when I'm, I'm looking at, the mechanism of action. Does it make sense? Is there, people always ask me about leronlimab. There's no publications behind it. There is just anecdotal evidence. And I said, well, if you listen to Dr. Patterson, and he's come out and he's explained it in such a beautiful way, and your videos on it were just incredible. And I think your immunology is hands down. I was telling Ahmed, I wish that we had you in medical school. It would have saved us so much of time. We would have had more time playing basketball and goofing off than if we had you around. So again, very grateful for those videos. But you're able to explain the science. That's fascinating, rather than saying, well, this drug does quells the cytokine storm. Okay, but how? And so that's something I'm really interested in. Safety is always important. We don't want a drug that's going to harm people. I mean, there's a lot of mishaps in the history of medicine, of these, sometimes these medications that have been out in the market and they've hurt people. Thalidomide comes into It's always on everyone's mind when you're in medical school learning about thalidomide. Efficacy, that's one of the top. Does it work? That's the question about leronlimab right now. A lot of these drugs is observational studies, anecdotes, but we got to see if it works. Route of administration. I think it's a really important thing that people sometimes forget when talking about the drugs, because you've got different ways of administering a medication. There can be orally, intramuscularly, subcutaneous, IV, intranasally, and inhaled. I think it's important to think when you're considering which medications for an outpatient versus inpatient. If you have, for example, remdesivir doesn't have an outpatient role because you got to put an IV, you got to run an infusion, and of course the cost of running that IV, the tubing, and the personnel. You have to have a trained personnel to be able to put that IV and then discard the waste. So there's a lot of cost behind it. There's a lot of time behind that, which is why when we're going to talk about some of these drugs, we got to see, if it's inhaled, perfect, because there's no injection now. Sub-Q, not bad. Oral, perfect. Oral, inhaled. So I want to just I kind of look through everything to that prism. The other thing is where in the developmental phase these drugs are, because if I tell you I got this drug that not only cures COVID-19 and influenza and HIV and cancer, but also solves world hunger and homelessness, and you're gonna say, okay, sign up. Well, it's in my computer. It's a computer model. Well, it's not clinically relevant. So it's really important to look and see where in the developmental phase it is. If it's a computer model or an animal model, it's interesting, okay, but let's talk when we can really sink our teeth into things. And the other thing is exclusion criteria too, because that was one of my biggest criticisms of remdesivir and even tocilizumab is it's being marketed as a potential treatment for COVID-19, but in my experience, most moderate and definitely severe and critical COVID-19 patients are not getting remdesivir because there's elevated liver and kidney from the damaged liver enzymes, and the exclusion criteria excludes these COVID-19 patients from getting a COVID-19 medication. And the same thing with tocilizumab. And I've experienced that firsthand with patients, and very eye-opening when, I didn't appreciate that factor until this pandemic. So I just want to sort of say, like, when I talk about medications or I said that I'm interested in this, I think this is just how I take those hundreds of medications and I'm able to streamline it.
Beautifully put. I love it. And for the cool beans here, a couple of gems that I picked up while you were discussing these. One thing that is very interesting, and I saw a comment on Dr. Richard Bartlett's YouTube video, and the comment was, somebody said, oh yeah, this works, why don't you show us a study? And I wanted to remind us all that medicine, when it starts, there is no study. When something begins, there is no study. Even the previous drugs for which there may be studies, there would have been a point when there was no study and somebody decided that it looks like mechanism of action may be useful, maybe it can be applied here, and then they became brave enough to try to see if they can study it on animals and then on humans. So medicine is not every medicine comes in with a journal to say this medicine is very good here. Repurposing of medicine happens all the time, and we are fortunate that for coronavirus, we are getting some medicines that can be repurposed this way. We don't have to always go and invent new drugs. We can probably use some of those. So this was a very important gem, that it's not just whatever is already prescribed or approved or whatever WHO has said. And I know that I'm dinging WHO over here. If they're hearing, they need to get their act together. This is how medical thinking is. This is how we are trained to think about these books over here. Some people actually put the comments out there that you want to make yourself look like a doctor by putting the books over here. I have read them all. I have read them all, and you have read them all. And other doctors and nurses and nurse practitioners and physician assistants, medical folks, they have read it. What they teach us are the mechanisms, and they teach us how to learn more. So this is a very, very important point. And then the second point is that there is such a difference in practicing internationally versus within the US. And again, we both are in the US, we both are here. So this is our country, and that is why we are saying internationally versus the US. So tell me this, Dr. Yo, do you think, and totally you can deny the question and say, no, I'm not going to answer it. Do you feel that if within the US we were given some more flexibility for prescription, the results may have been different?
That's a really hard question, because I don't think so. I don't think so. I think at least early on, because we were still trying to understand the disease. So we could have had leronlimab, we could have had linzolumab, we could have had EIDD, I think remdesivir was around sometime in March. But if we didn't understand the whole phases of it, it's not really going to have an effect. If we give an antiviral in the immunological phase, then yeah, we're going to say that this antiviral doesn't work. So, sometimes hindsight is 20/20. It's sometimes we'll say, well, if we know what we know now, and we had more tools back then, I think maybe, but I don't think. I don't think it would have made that much of a difference, because we're still trying to understand the disease.
Okay, let me ask you a follow-up question. The follow-up question is, now we know much more, right? The world has gone into this pandemic for about 8-9 months. Now we have, somebody said that, why do we have for this virus so many drugs popping up from everywhere? And I responded and I said, at this time, what else the world is doing? We are all, the whole world is trying to figure it out. So definitely there's going to be a lot of experimentation. So let me ask you the follow-up question. What we know now, how would the situation in the US become different? What should we do different? Or are we on the right track, in your opinion, in your research?
I think we've gotten better. I think early on in the disease, I think there was an over-reliance, and as an anesthesiologist, I wouldn't have a job without a ventilator. So I'm about to criticize ventilators, and I want to just put that out there that I wouldn't have a job. So I love ventilators. Let's put it that way. But we have an over-reliance on ventilators. It was, patient came in critically ill. I don't know what to do. There was a lot of fear, a lot of doctors. I don't know what to do. Well, why did you give hydroxychloroquine? We didn't know what else to give. That was the only thing available. So there was definitely, I don't think our medical system, our medical training was prepared for a pandemic. And it's definitely, once all of this is done, and hopefully soon, all this pandemic, we can do an assessment and see how we can get better as a medical community and education and whatnot. But I think that the thing with early on in the disease, there was a lot of fear, a lot of panic. And what people said was, if the patient goes down the tube, I've got the ventilator. And I can put them on pressors, and we will, what I called in my videos, checkbox medicine. And it's not to be critical. I practice checkbox medicine. We all do. It's sometimes as physicians, we stop being physicians, we start becoming technicians. And we have to stop with that. We have to start critically thinking, not being afraid, really opening our minds. And I think a lot of it is, you start doing that, and with social media, with how things are these days, you're going to immediately be called a quack. And I think a lot of people are afraid of being called a quack. I've seen Dr. Bartlett being called a quack.
I have been called quack many times in the YouTube comments as well.
And right. So, right. I mean, we all have gone through that, and we sort of get a thick skin in being on social media. But I've seen Dr. Zelenko. I mean, his name gets dragged through the mud. I've seen Dr. Marek, people talking about all these, well, he's just giving vitamin C. And I've read studies that, okay, well, what if you're going to be critical, what's the solution? Come up with something, because then that's what I said my earlier comment about how I appreciate that. Okay, you did something, you're doing something. Whether it's right or not, we don't know, but it beats saying, I don't know, and just letting your patient go down the tube. And I think there was an over reliance on intubating and putting them on a ventilator. It's funny. I had a lady from Chicago who called me. Her mom got on the ventilator, and I said, I can probably tell you what the vent settings are. And she goes, I mean, the PEEP, the tidal volume, the FiO2, and she goes, oh my God, you're exactly right. I was off a little bit on the tidal volume by maybe like 50 mLs. She goes, how did you know that? I said, because it's in the manual. Check medicine. So I think we've gotten better with the management. I think just looking at charts and speaking with ICU doctors all over the country, I think there's people. I think if a patient had a little mild respiratory distress and their SATs were in the 80s, going to get tube and get on a vent. But I think now that a threshold is gotten, we've gotten higher in terms of when we're going to intubate someone. So I think that's been one of the key differences in the management that I'm seeing is there's not a reliance. I think people understand the mortality rate was something like 80% for patients that got on that were intubated, and the ones that survived, a lot of them ended up with trachs, with tracheostomies, and that's a lifelong permanent scar, even if they do get that reversed later on. So they've now got scars from all of this, and psychological scars and the physical scars behind that. So I think the important thing was the less reliance on a ventilator. I think is sort of dramatically. I think we're seeing some improvements in the mortality. I think also there's a better appreciation for the immunological phase, the cytokine storm. Early on, I got really involved in COVID management when one of my former anesthesia colleagues came down with COVID. He got intubated, very, very ill down in Florida, and his family called me. And that's when I really kind of put on my researcher hat and started digging into COVID. And I found there's a lot of the research from SARS and looking at the research from SARS and MERS, and to sort of learn about what they went through. And it was a blip on the radar. It was contained, so we don't have a lot of data. But it was very interesting. A lot of the Chinese researchers were suggesting that cytokines were playing a role in the whole cytokine storm. And for your cool beans out there, we talk so much about cytokines. It's all over these days, but cytokine and the cytokine release syndrome have been around. We've studied cytokines for such a long time. It's not this new thing, but I think it's a better appreciation for the role of cytokines, especially that immunological phase. And so I think when we start saying, okay, there's a viral phase and an immunological phase, now we can say, okay, we're going to hit that phase 1 with an antiviral. We're going to hit that phase 2 with either an immunomodulator or some sort of immunosuppressive or some way to redirect those immune cells, which is why now, there's all this discussion about those monoclonal antibodies, leronlimab, lanzulumab, itolizumab. So I think that's, I think the management has gotten much better now because we understand. See, and that was my initial. Once you understand where we are, it's easy now plugging in medications where they need to be.
Got it. So I'm going to ask you a couple of more questions, and then I want to go to the Cool Bean questions as well. I love Cool Bean community. I did not know that I would end up setting up a community that is so informed and educated that they can actually think about the mechanisms going on and then think about a drug and map the mechanisms and do the medical thinking with them. So this is beautiful. I love them all, and I love how we have learned together. Question for you. And let me just ask you some rapid questions first, and then I want to talk about some drugs. First question, what do you think about masks?
What do I think about masks? They
essential, non-essential.
Essential. I don't even think it's even a discussion to be had.
Done. Second question, what do you think about schools reopening?
This is a tough question. This is the hot seat question.
The tough questions.
This is a tough question. My sister's a pediatrician, so I talk to her regularly. She's with the health department, and we talk a lot about the school thing, and I asked her, "Do you want to be the health commissioner?" And she goes, "No, no way," because it's a very tough question, because we do know that kids are have high viral loads. They have more or less ACE2 receptors, but more viral loads. And if you look at the mortality, I mean, it's very, very, very low. I think I think it's about 45. You start to see the rise. So we do know that the kids, in terms of mortality, but they're going to go home to their parents. They're going to go home to their grandparents. So it's not as easy saying, well, they're not going to get sick, so send them to school. The other tough thing about the situation is the teachers. What do you do about the teachers? Because obviously a lot of them are going to be much older. Do you do Zoom calls? Do you video conference them then? But then the problem is, how do you moderate? Who's going to be moderating those kids in school? You always got those disruptive kids, which I was one. I was the one that threw spitballs in the back of my class. So that was me. So how do you control that kid? Who's going to moderate that? There have been discussions about having high risk kids stay at home and having sort of healthy kids come to school. But the problem is, again, you've got to put resources to now screen those patients, those students. What is high risk? Someone with asthma, is that high risk? I mean, most kids with childhood asthma, I mean, they grow out of it, but what are we going to put all the 8-9-year-olds in with asthma, childhood asthma at home? So what is that cutoff? It's a very difficult decision.
Got it. So,
and I will say one more thing just about that, Dr. Bean. I teach. I have a grant with the Rhode Island Department of Education. So I have twice a week. I have kids that come in, and I teach them principles of exercise physiology and nutrition and whatnot. Because these kids, they were in middle school and high school, and everything's been shut down. And seeing them, I have about 10 of them. They're all masked in my facility, and they're all socially distancing. But just being that human interaction, you could tell. I talk to the kids about COVID every time they come in. And you can tell that it's really affected them. A lot of them had told me they were so depressed. They're just sitting at home. Their organized sports are no longer there. So we have to be, I know it's so easy saying, okay, no school, no activities, but there's a psychological thing that is taking place with our kids that could be a problem. And I don't know the answer to that. So I'm going to call a pass on that.
Yeah. So you actually caught my next question as well, that if the kids stay home, what is the psychological impact? If they go out, what is the risk to them? So you already answered that. So next question, and we're going to talk a little bit in detail in vaccination, but I want to ask a rapid question first. Current vaccinations, people say they are rushed, they may be risky. What do you think?
I'm skeptical about vaccines. We're looking at the 8-point scoring system. The mechanisms are there. Fascinating. The different platforms that we're using, the mRNA, the DNA, the adenovirus. But none of this have ever been used, tested, or successfully in humans. When you look at the trials that they're doing, and they're comparing the data to the convalescent plasma, convalescent antibodies, looks very promising. Moderna, I like the Imperial College. Novavax just came out with their phase 1, the nanoparticle. I think you said something like 4 times the amount of convalescent antibodies. So the mechanism is interesting. We're still not sure about the safety behind it. Some of them are having some serious events. No one has died from the trials, but when you take it out to the general population and you tell, oh, okay, that was 5% or 10%, whatever number had serious side effects, people automatically, the lights go off and they say, wait a second, I don't want the vaccine. I want to wait. I don't want to be the guinea pig. I think the other interesting thing, the other important thing about the vaccines, Dr. Bean, is, there was the New England Journal of Medicine came out. I think Dr. Yang and the researchers at UCLA, they were talking about the how long do those antibodies last? I mean, it's a question of, you can build the antibody and you can have those high titer levels, but the question no one can answer until once we're in the middle of it is, how effective are those antibodies going to be against COVID-19? And the second thing is, how long are the titers going to last? If you look at the protocols of these vaccines, a lot of them are requiring 2 doses.
Correct.
And we got to think about, first of all, you're going to have a skeptical public. I think if you look at some of the polls and people talking about it, they're already skeptical. So now you're going to tell them you have to take 2 injections. How do you organize that? It's hard enough getting someone to a clinic. It's hard enough getting him to an urgent care, to the hospital. Then you got to tell them 28 days later, and it just doesn't seem very practical to me.
Got it. So we'll talk a little more about various vaccines. Now I'm going to go to the question. I wanted to have some rapid questions from you as well about these things. So tell me this, and you've touched upon that a little bit before as well. When looking at leronlimab, lenzilumab, itolizumab, how do you compare and contrast them? What do you think? And if you can throw in some data from the ICUs as well, where you're working, what is it that they're doing over there? What kind of effect of these drugs, available, not available, what's happening?
Yeah, absolutely. I think the important thing to remember is any experimental drug that we're talking about, getting an EIND is very, very difficult. A lot of families have said, well, if I wanted, I'm willing to sign the consent and I should be getting it. Well, it doesn't really work that way. It's the ICU doctor is the principal investigator. They have to get IRB, the hospital CEO is involved. There's so many different players, pharmacies involved, and there's so many rate limiting steps to that. So none of them are being used unless they're in a clinical trial. And I think the FDA, in terms of leronlimab, I think there was something about not issuing EINDs, and they want everyone enrolled in clinical trial sites. So I've had patients that were willing to drive, that gentleman in Arizona, he was to drive hours from Phoenix to Los Angeles to enroll in Dr. Yang's leronlimab trial. So you see that desperation, that human element of things. So when you're looking at the 3 different drugs, I've talked a lot about leronlimab because, again, Dr. Patterson has really been very clear about the whole mechanism of it, and it's a beautiful explanation, and you've done a wonderful job, like I said. I also like itolizumab. I'll sort of brush over leronlimab a bit because we've beaten that, so many videos. We talked a lot about it. Itolizumab is very, very interesting. It's made by a company called Biocon in India. I actually had been emailing with Seema Ayuha. She's the sort of the vice president of communications. I listened to their press conference. I got to admit, I was so impressed with what they were doing in India, and it really shines a light on what investigators and researchers are doing overseas. Their level of understanding was just unparalleled. It was at the level of Dr. Patterson and Dr. Yang and even you, just the way you're describing things. I was floored. It was like 2:30 in the morning, and I've got my laptop listening to India, this conference call from India. So it's interesting. Itolizumab inhibits that CD6, which is an arm of the T cell, which I think in one of your videos you beautifully described it. And it's interesting because I always find myself sort of talking to Dr. Patterson, someone whose mind I respect a lot. And I'll say, well, what do you think about this? And he will somehow find a way to connect it to RANTES. And we found a study. It looked at a rat model in kidneys where RANTES inhibited CD6, or the effect of itolizumab or the anti-CD6 monoclonal antibodies would cause a inhibition of RANTES, which was very, very interesting. And when you're looking at all these monoclonal antibodies, and there are many other ones that are investigated, and I'll be honest with you, I can't keep up with all of them. We're trying to find the quarterback in the game. Who's the quarterback? Who's the one directing the offense? So the leronlimab team thinks it's RANTES. Itolizumab thinks it's CD6. Lenzilumab, which is made by a company called Humanigen, they're thinking is gm-csf. And every one of them that supports the drug they get very territorial. I get these messages on Twitter all the time. Well, you talk only about leronlimab. What about lanzilumab? So I'll talk about lanzilumab, and someone will message me, well, you no longer support leronlimab. And I try to bring it back to the human element. It's not supporting. This is not cheerleading. This is about trying to find an effective. We don't know which is the quarterback. And here's what I'm starting to realize: there might be multiple quarterbacks in the game, and you might have some sort of vested interest in whatever drug it is. But the reality of it is, we're going to need multiple quarterbacks to play. So
Absolutely.
we have to have an open mind about that. There are different things that I like about each drug. With itolizumab, their study was beautiful. It's a randomized controlled trial. A lot of criticism because it was a small study looking at only 30 patients. But you mentioned this earlier, Dr. Bean. We're in the middle of a pandemic. Running randomized controlled trials in a non-pandemic situation is really difficult. In a pandemic, I mean, how do you set up controls? How do you tell someone that they're going to get a placebo or saline? How do you do that? And then here's the other ethical dilemma. You want the cases to go down. You don't want COVID to spike up, but you need COVID cases to do their experiments and study. So every one of these hospitals, they're not only studying leronlimab or itolizumab, they're studying 15 to 20 different drugs. And each of them, you need patients enrolled in them. So I think people need to understand it's not very easy. They'll say, okay, just get these patients enrolled. We can get them enrolled in a week. Well, no, it's not. It's not that easy. You need 200, 300 COVID patients. They have to be willing to sign to do experimental treatments. You got to get hospital or IRB. The hospital the pharmacy has to be involved. The FDA is involved. You have to send blood samples. So it's a very, very, very difficult process.
Makes sense. So let me just a quick note here to the cool beans who are listening. Please do me a favor. There is a lot of very useful information over here. Dr. Yo has been researching, digging in, figuring it out, and he has shared a lot on his YouTube channel as well. He is very active on Twitter as well. So please do me a favor, follow him, subscribe to him. And if you like what we are doing, like, subscribe, and share to Dr. Bean as well, medical lectures too. So if Dr. Yo, if you have some more time, we are 49 minutes into it. If you have some more time, I want to go over some of the questions that the cool beans have posed. Eventually, we are sitting here for them. So would you have some time to discuss some questions from them too?
Absolutely. I'm a yapper, and so I'm happy to talk.
Absolutely. So what I'm going to do is I'm going to share my screen. So cool beans, I'm going to first go over the Twitter questions because these were submitted before. Then I'm going to go over the questions that are here in the live chat as well. And we're going to talk some of those too. So I'm going to share my screen and talk about the Twitter. So here is the Dr. Bean site. Please check this out as well. Very recently, Facebook has taken down one of my videos. Interestingly, I had shared my own post, and they blocked it by saying that this is a post that was incorrect. And the original video is still there, but they blocked my share. So something weird is happening there. So first of all, I want to show you today, Dr. Yo had, so if you can see this one, I really, really love it. So before we start with the questions, Dr. Yo, here is WHO. So guys, I don't think you're going to believe it. Here is WHO saying preliminary investigations conducted by Chinese authorities have found no clear evidence of human-to-human transmission of the novel coronavirus 2019 identified in Wuhan and China. I am speechless. I don't even know what to say to this coming from WHO. I actually, when you tagged me, Dr. Yo, I actually thought that this was a fake account that was kind of making fun of WHO. And I loved this. So here is your response. I love this. So with this, let's start from my response was I had tweeted, you follow crows and you end up on dumpsters. So here are some questions.
Dr. B, if I just might say one real quick, just along those lines, yes. The CDC also very early in the pandemic they told, do not wear masks. The only people that need to wear masks are if you are taking care of patients like healthcare workers, or you have symptoms. And in some of my earlier videos, I did talk about that. Many other doctors did. We follow the CDC. And I'm embarrassed. And so many times I wanted to make a video and say, I'm sorry and I apologize. And I understand why there's a discussion and debate, whereas many other countries in Asia, the Czech Republic, I know Czech Republic did a whole thing on YouTube. Back in April, they were putting videos out. We all wear a mask and we have very low transmission of the disease. And here we are, the CDC telling us, oh, masks are not needed. I remember going to the supermarket and looking at people wearing masks going, well, there's no need for that. We trusted these organizations. There's an erosion of that trust, which is why there's so much of confusion and debate about things.
Absolutely. And on the point of masks, in the beginning, if you look at my videos, early videos, I had also taken CDC's advice and started saying that masks are not necessary. And then at some point, what happened was I watched a video from a South Korean doctor who had been leading their pandemic early on in 2012 when this was the MERS-CoV, and then now. And he had a very simple statement that just shocked me and woke me up. And he said, in South Korea, we primarily managed this with so less or so fewer deaths is by masks. And he said, I think, and I'm paraphrasing him, he was talking in Korean. He said, I think that the West is making a mistake of not having the masks on. And when I heard that, it changed something in me as well. And I started going and started looking at the mask research. And then I went so there is a book over here for microbiology in which I went and I saw that the masks are necessary for coronavirus because these are airborne. So anyways, that is where CDC took one and then other, and then WHO took a side and the other. And unfortunately, not only they are, and honestly, I sometimes feel it is okay that they do not know something. However, when they can figure out things, when they have such large staff, why can they not do research like you and I do? That is what amazes me. So let's start with this question here. So first is the Rajul. So he's saying, what are the chances of getting COVID-19 if we purchase vegetables from wheel carts? So how about these open air carts? And if we purchase from there, what is the chances of infection?
Yeah, I think that's a real good question. I get that quite a lot. That the thing with any fruits and vegetables, washing, like it's like why hand washing it the spike proteins will actually bind to the surfaces, and when you wash with water, you rinse it out thoroughly for about 30 to 60 seconds. That usually does do it is effective. The other question I get asked a lot is using soap. Should I use soap for my fruit and vegetables? It's a very tough question because if you talk to most food experts, they'll say no. If you have some of the soap suds that are still in the fruit and vegetables, it can cause some stomach discomfort. But at the same time, we're dealing with a pandemic and a novel virus. And if someone uses soap and water and they thoroughly wash it, let's say they do it for 2-3 minutes, I don't see any harm in doing that. I know it kind of maybe goes against some of the food experts, what they say. But I think I just wash my fruit and vegetables. I just run it over water for about 60 seconds, and I haven't had any issues.
Same here. I'm not a fan of washing it with soap. So Rob from Florida, so he has many questions here. What are his thoughts on prophylaxis treatment protocol for kids going back to school? So should they get quercetin, vitamin D, vitamin C, and some other prophylaxis, or you think that it's okay? What is your opinion and research?
Yeah, I haven't, a lot of these, a lot of the prophylaxis what we talk about with the supplements you just mentioned, there aren't really a lot of side effects. The important thing to remember with pediatrics is that it's all weight based. So like in adults, I can say 2,000 milligrams of vitamin C, but in kids, we have to go by weight. And one of the things we have to remember, pediatric physiology, they're so different than adults. It's until about the age of 12. Their brains are maturing. Their cardiovascular system is different. So I'm always very, usually with adults, I'll say, okay, there's no harm done taking some vitamin D, vitamin C. But with children, I would say just always check with your pediatrician, and don't take something over the counter, because it all has to be weight-based.
Makes sense. And I want to once again remind all of the cool beans over here, none of the discussions here are a prescription. This is two doctors in front of you discussing, thinking aloud, thinking with you. I'm proud that many of you are actually cool beans for some time. You understand the mechanisms we discussed as well. So this is more of an educational, informational session, not a prescription for any single person or persons. And then we are not your doctors as well. So please don't put yourself in trouble. Next question from Rob. What kind of aggressive treatment would be recommended to pediatrician for children patients who show a fever or symptoms? So now he's looking for what should a pediatrician do if they are seeing a child who is sick?
Yeah,
and again, please feel free to pass if you like.
No, it's I think these are all great questions. You get a lot of questions on peds, and I'm not a pediatrician, but the thing with pediatrics is my background is in infection control and in the pediatric and the neonatal ICU, so I kind of have a little experience dealing with this situation. The thing with you can't, with COVID, there's so many other infections. There's still influenza, there's RSV, and I think recently up in the Northeast, there's the Eastern equine encephalitis. So you can't just automatically assume because a child has a fever or maybe some lethargy that they have automatically it's COVID. I think also the other important thing kids and parents need to remember in the summertime is there is an amoeba called Naegleria fowleri, and that can cause sometimes, if you look at some of the symptoms, the fever, the myalgia, and the kids eventually get into a coma within 24 to 48 hours. But you look at the overlap, and there are a lot of similarities in that. And so especially in the summer months when the kids are out and the mosquitoes are out. So it's a little bit difficult to say, what would be the treatment. I think the important thing is, because COVID is so prevalent, if the child has been around exposed to someone that had the infection, or showing some of the signs and symptoms, let's say of a upper respiratory tract infection, they should get a test first before jumping to any conclusions.
Got it. And then one more question from Rob. And Rob, please don't be offended when I request Dr. Yo to pass if he likes. I just want to make sure that I don't put him on the spot where it is difficult, because again, we're not prescribing. So final question here, at what point is it worth going to a doctor to actually get tested or treated with cough? So what are the symptoms? When should you get worried and say, all right, I'm going to go to a doctor?
Yeah, so that's a very tough question, because that's assuming you have access to a doctor, and that's assuming you have insurance. And let's put it this way: every time you get a sore throat or a scratchy throat or sniffles, if we all run to the doctor's office or the urgent care, we're going to overwhelm our health and medical system. But with that being said, you have to put everything in context. If you're having high fever, you're having myalgia, you're having some diarrhea, loss of smell, some of the classical symptoms that we hear, definitely go to your doctor. If you're having, if you've been around someone, if you've been exposed to someone who you think has COVID, even though you may not have symptoms, you should go get tested.
Got it.
Again, it's a very tough question, because I don't want to tell someone, okay, you have a sore throat, immediately run to the doctor's office, because we're going to overwhelm our health system. So I think we have to look at context. Is really important.
Yeah, absolutely. So the context could be that, have you been in contact with somebody who's COVID-19 positive, or are you living in an area of outbreak, or have you started seeing some of the severe cases or shortness of breath, etc. So the WHO, funny that I'm talking about them, they have a list of reasons that can make a person suspected case, and then you must go. So please look that up. Continuing, DRU here, a good friend from South Africa, he's saying, and everybody over here is a cool bean, and they're all my good friends. So he's saying, very passionate, good choice. If we leave parcels, so Rajul here, if we leave parcels out there once we receive them, How long should we leave them out? When is it safe to start handling the parcels or deliveries?
So I guess the question is about sunlight. Very, very interesting. You know, there's a lot of studies that say, well, you have to leave it out for 8 to 12 hours, sometimes even longer, to potentially inactivate the virus. You know, I've gotten this question a lot. I put out a video on about Amazon packages, and the way I look at it is the risk of transmission is really, really low. It's about the number of viral particles. I think if you look at some of the virology, the number of viral particles that you get exposed to. So the more viral particles you get exposed to, the higher risk you have of getting infected and showing symptoms. But that's being said, you could get exposed to one viral particle and you could theoretically get sick. So I don't want people to think like, okay, well, I should be okay because I got less viral particles. I don't want to say that, but very low risk. I think some of the data and some of the literature out there says it's highly unlikely. But if you wanted to be cautious, what I would say is open the packaging, the outer packaging at home, and then inner lining, wipe it with any disinfecting solution like a Clorox or bleach wipes. And the end of the day, and this is I would probably say this is high up there with mask wearing. If mask is 1A, this is 1B, hand washing. So the number one thing you walk into a hospital, infection control, is wash your hands and wash it effectively. And that is usually, you know, we say sing happy birthday, the happy birthday song, which is about 20 or 30 seconds. Which, by the way, there's also a Stevie Wonder version of Happy Birthday, which is 5 minutes. I don't recommend you guys singing that one.
Okay, got it. Thank you very much for this one. So then there is a question from Chris Savage. What therapeutic treatment does he feel are most promising for helping the COVID-19 pandemic? What is it that you would hang your hat on?
So, you know, obviously I've talked a lot about leronlimab. I do like in India's itolizumab, very, very high on that drug. It's one of those things we don't know which is going to, you know, if leronlimab doesn't show efficacy, well, we got to find another solution. We can't just sit there and mourn and say, well, it didn't work and FDA stinks and whatnot. So I like India's drug. They're doing clinical trials. They're partnered with a company called Equilium in California. So they're going to start doing clinical trials in the US. They have what would be their FDA EUA approval in India. So I'm really interested to see what they're going to show. Lenzulamab, interesting. It's by Humanigen. They inhibit the gm-csf. I think it has a role. The difficult thing about Lenzulamab, in my opinion, is as a clinician, it puts a lot of pressure because if you inhibit the CSF very early, you inhibit the myeloid cells, which you can't have immunosuppression. You need those cells, those immune cells to fight. You need your army, you need your military to fight. And if you give it too early and you inhibit the GM-CSF, you knock out the myeloid cell line. It's like knocking out your Air Force and your Navy very early in the battle. But if you look at some of the literature and the virology, the GM-CSF actually, it can have an effect sort of in the later part of especially that immunological phase. So I definitely think it has a role. It might put a little bit more pressure on clinicians. The other two drugs that I'm really like is the company Synergen with the interferon beta, which again, your video on that, on the description of it was wonderful. Because you're really using your body. What I like is our body has sort of natural defenses, and it's almost like you're, you know, I hate using the term boosting an immune system because I don't believe you ever boost the immune system, but I would say like reinforce. You're reinforcing your more soldiers on the battlefield. So I really like. It'll be interesting to see what the studies, what their randomized trials show. The study had some flaws in it. They had a little bit more sick patients in the control arm, so it's very hard to say conclusively, you know, if this is going to work or not. But that's a drug I really like. It's an inhaled drug, and as we're talking about route of administration, it's a great drug for outpatient. great. There's not, the learning curve won't be that high. So I think I really like that drug. There's another drug, and it's not going to be, they're not going to do clinical trials until 2021. It's a drug called Neumifil, Neumifil. It's made by a company called Pneumogen. They're a company based out in Scotland. Very interesting. What they've done is they've developed a drug, and they've only done it on animal models so far. They're doing human trials in 2021. Where they found the spike protein of the COVID-19 is covered by a glycan. It's a sugar covering. And what they've done is they're developing a drug that blocks that glycan, or it inhibits that glycan, where now the spike protein on COVID-19 cannot bind to the ACE2 receptor on the type 2 pneumocytes of the alveoli. Excellent. It's a novel way of thinking. And the last thing I want to talk about is something called galectins, and people that follow me hear me talk about galectins. And real quick, here's the quick rundown. It's a carbohydrate protein that's expressed in all our cells and on all mammalian cells. And what it does is they're part of signal transduction. There's a lot of role that galectins play. They're usually found heavily concentrated in the cytosol of cells. And what's very interesting is galectin-3. There's numerous galectins, but galectin-3 has been studied extensively. And they found that there's a researchers in the University of Illinois who I've been talking with, wonderful, wonderful team of doctors and medical students who are writing papers on this. They have identified that the spike protein on COVID-19 has a similar structure to human galectin-3. So now there's a lot of research going into galectin inhibitors where if you have a drug that inhibits galectin-3, you might be able to inhibit the spike protein and neutralize the virus right on entry. So this company in Scotland has made Neumifil, and they're trying to look into a way of neutralizing that spike protein. Really incredible stuff.
Love it, love it. And just for the cool beans over here, I'll be talking about galectin in a couple of days as well. So thank you very much for the segue, Dr. Yo. I'm going to continue with the questions here. So are there two phases to leronlimab CCR5 blocking action? In HIV cancer, it prevents nasty things from entering the cells. And in COVID and in NASH, we see much more subtle immunomodulation. So commonality, oversimplification, how do you see it?
Yeah, this is the interesting thing about leronlimab. There's all this. It's one of those things, as Dr. Patterson said, in what they knew about leronlimab in 2010 versus 2020. It's light years, and there might be more things they find out about COVID-19. Very interesting. Dr. Patterson will talk about how when he was in China, he was looking at the data and thought to himself, "Wow, maybe leronlimab can have an effect on COVID-19." So what we know is with HIV has the GP120. It's a receptor, a glycoprotein on its surface that it binds to the CD4 plus on the T cell, and it has a co-receptor, and the CCR5 is the co-receptor, and that's the one that's been extensively studied. That's not a new finding. I think there is a couple other CCR5 antagonists that have been out. I think Pfizer or Merck with Marabirac in 2007 got their approval. So that goes by occupying the CCR5 receptor, you're preventing that co-receptor, and so the HIV cannot bind very effectively onto the T cell. In COVID-19, and also really the same principle applies for cancer metastasis, is where RANTES has been described as, I've always described it as a pheromone. Dr. Patterson's called it a magnet. I think Dr. Bean, you've called it a police siren in your description. So we all have, again, we're all trying to really describe the same thing, where you're attracting these cells. And in COVID-19, you're attracting these T cells to the site of inflammation that can worsen or cause the cytokine storm. In cancer, you're really basically taking cancer cells and you're just sort of attracting them to the sites of metastasis. So by inhibiting that, you're blocking that signal or those cells going to sites of metastasis, and so that's how that works. So it's a very interesting mechanism. The mechanisms behind it.
Got it. So these are the questions that are from the Cool Beans from Twitter. So now the Cool Beans that have been here live. So another 10 minutes, if I can go over some of the questions from the live audience. And live audience, I know that we are 1 hour, 10 minutes into this. So if your question has scrolled way up, please do me a favor and type that again. I'm going to try to get in as many questions as I can. We have Dr. Yo over here. I am happily, you can see from my face at how I'm glowing that we have Dr. Yo with us, and listening to his talks and the mechanisms and how on top he is of this all. So let's ask him more questions. So there is a question here that is, I just saw this. Are there any tests available that are able to detect any asymptomatic patients before becoming symptomatic?
Yeah, that's, Chantal, that's a wonderful, wonderful question. And it's a question I posed several months ago in one of my videos when I talked about we need to develop a sort of a risk scoring stratification system. I'm not a believer in, I think people say, okay, what about RANTES or what about interleukin-6? I'm not a believer in a solitary lab value. I'm not a believer in a solitary clinical value. You'll end up chasing and going around in circles. To get a full picture, you need several different markers. And right now, we don't have any tests, but it'll be interesting to see if we can identify the main quarterbacks in this disease, then we can develop risk stratification. I proposed a 10-point scoring system. So if you say someone from 7 to 10, then they're more high risk. And so we get more aggressive. Maybe we consider steroids. Maybe we consider monoclonal antibodies sort of a little bit earlier in that viral stage. These are just suggestions. Just thoughts I've had. So it's important to risk stratify these patients. And right now we don't have anything.
Got it. So then there is a question here. What do you think about the paper tests that Dr. Meena talks about? And I am not aware of this, so I can't help.
I don't know about the paper test, and I don't know who Dr. Meena is. I'm sorry. Okay. I'll have to look into it.
Okay, perfect. So how about this? And you had actually tweeted that you're going to talk about this. So how about aviptadil?
Yeah, David, great question. And this has been in the news. If you guys have been following the news in the last couple of, in the last 24 hours. So it's made, aviptadil is a vasoactive intestinal peptide, or a VIP, and that's where the VIP is in the aviptadil. So it was originally isolated as a vasodilator and a hypertensive medication in 1960. So it's been around for a while, and it's got a couple of different functions. It's an immunomodulatory, it's a vasodilatory, it relaxes smooth muscles, the GI. In fact, it's been used for erectile dysfunction, and it's produced. There's something called neuroimmunotherapy. Neuroimmunology, which is a whole different cascade. Which I'm sure, Dr. Bean, there's some topics for you to dive into. Which, like I said, you do a wonderful job with that. So
thank you.
And it's been studied. VIP has been studied extensively in rheumatoid arthritis, Crohn's, diabetes. So it's very interesting. What this drug does, it actually has two different mechanisms, and the company hasn't really talked about it. I kind of did some digging into it. Aviptadil. So the VIP is secreted by, if you're looking at it for the immunomodulatory function, by a lot of T cells, especially the T helper 2 cells. And what it does, there's a high concentration of VIP in the type 2 pneumocytes in the lungs, the area, the site where the ACE2 receptors, the site where the spike proteins are going to bind to. It's the ACE receptor. ACE2 receptors are the type 2 pneumocytes. It can be a tongue twister. So what one mechanism of giving aviptadil does is it blocks or occupies those receptors. So now the spike protein is unable to bind to the ACE2 receptors. It's almost acting like an antagonist on that site. Now the other mechanism of action is it acts as an immunomodulator. Very interesting, because leronlimab has been described to Dr. Patterson as being an immunomodulator rather than an immunosuppressive. So, but the very interesting thing is, I'll just quickly talk about I'll just run through the immunology real quick. You guys can refer to Dr. Bean's wonderful talks. So what it does, it inhibits interleukin-2, which we know that it fires up the cytotoxic T cells. It inhibits interleukin-12, and promotes or upregulates interleukin-4. So it's really kind of pushing towards the T helper 2 pathway and away from the T helper 1 pathway. Very interesting enough, and this is why I posted this on Twitter. I was reading a study in an immunology textbook. This is what I found. VIP inhibits the expression of CCL2, of CCL, and CCL5 grantees. I fell off my chair, texted Dr. Patterson. I said, could the mechanism of action, because they just released, they didn't talk about the study, but what they did, they looked at 15 patients in the study. It's a joint venture between a company in Israel and the United States. And they said they were able to take 15 patients, some of them on ventilators and ECMO, and within a couple of days be able to get them off the ventilator. There's an ARDS study that's been done. It was not COVID. It's an ARDS study. They looked at 8 patients, and of the 8, 7 of them within 5 days came off the ventilator, and 6 of them survived. 1 of them died from a non-cardiac event. So it's got some definitely showing a lot of promise, especially in the respiratory disease. But the interesting thing was with RANTES, because how it could that be the mechanism of action here? So it's got some overlap between leronlimab. So it'll definitely be a drug to keep in mind. Point, it's nebulized. So when we're talking about treatment, great outpatient drug, potentially great, obviously inpatient too.
Got it. So last couple of questions. So one question is here by Ivo. When should someone show improvement after a plasma transfusion?
Yeah, so I'm assuming this is about convalescent plasma.
Correct.
It varies. So the idea behind convalescent plasma is it gives your body enough time to build up your own natural immunity, because over time the convalescent antibodies are eventually going to fade away. I'm not exactly sure. From my experience, I would say, and talking to doctors, usually I'm seeing it about 3 to 5 days, and that's a big if. They show any benefit. I will say this, going back to our timeline, convalescent plasma might have a benefit sort of that early immunological phase. I don't know if it has. I haven't seen too many cases where it's been effective in the severe and critical. So that's just what I've seen. Someone else might differ and see something else differently than me.
Yeah, I have a similar observation as well. So last question, and this question has been, so Bern, thank you very much for curating it as well. This was asked many times. So echoing the questions already mentioned, best vitamin supplement options for prophylaxis, vitamin D3 or what else? So I just want to say this, that prophylaxis is really not very well known yet. But if I would restructure this question and say, what do you think should be necessary for an optimal immune system that is functioning on all cylinders, what would you suggest?
I think the data is evident that vitamin D plays a role. The vitamin D receptors on our immune cells, especially if you're vitamin D deficient. If you're a normalized vitamin D, I don't think there's any benefit in taking high levels. Very interesting enough, we talked about the MAT protocol. I've come to appreciate, and this is coming from my friend, the anesthesiologist. He had neutropenia. He's almost got a macrophage picture. And when you start to see decrease in neutrophils, the one medication or the one supplement that actually has been shown to help with regeneration of neutrophils is vitamin C. So I've come to, in the last couple of weeks, really appreciate the potential. I don't want to say conclusively because it's very anecdotal. We don't have any evidence. A lot of the data says 2,000 milligrams. I think Dr. Marek has talked about 4,000 milligrams. High doses of vitamin C are not going to hurt you. So I would say vitamin C, vitamin D, zinc, quercetin. I think Dr. Zelenko has talked about the gun and the bullet analogy, which I thought was wonderful. But the zinc. But the thing with the zinc, again, you have to get it really, really early. Really early. It puzzles me because we take coldies and we take zinc tablets. And I remember being in high school and everyone telling me, you got to take it when you start to feel a scratchy throat. And here we are debating about zinc. It's going, wait a second, it works, but you have to give it very early. In terms of prophylaxis, I'm not exactly I don't know if it has any prophylactic use. The other thing is N-acetylcysteine. 600 milligrams has been suggested by some of the studies as having some anti-inflammatory properties. And melatonin, sorry, and melatonin, that's the other one.
Absolutely, absolutely. So Dr. Yo, thank you very much. This has been, I think, if we can share this one video, it has encompassed almost all the topics that we've been talking about for so long, and they're all compressed down in this 1 hour, 20 minutes. So it is a very valuable video. Please, guys, please do me a favor, share, subscribe, and like as well. Please follow Dr. Yo. His Twitter handle is in the description to this video. Subscribe to his YouTube account as well. Dr. Yo, thank you very much for your presence here. You increase our ambience of this channel. Thank you.
And thank you, Dr. Bean. It's wonderful that we can be, create a community, and I'm also part of the Cool Beans too. And then we can collaborate and hopefully, we can continue in our discussions. And I'm looking forward to your lecture on Galectins, because I think it's going to be a groundbreaking field. So I'm looking forward to your research and your videos.
Will do. Thank you very much once again, and have a good night. Thank you for joining us so late and for so long.
Thank you, Dr. Bean. Thank you, everyone.